In an immune emergency, the timeline from initial symptom to system collapse is measured in minutes. Misidentifying the underlying molecular mediator guarantees intervention failure. To organize this response, we evaluate patients against 4 distinct clinical endpoints: anaphylaxis, isolated urticaria, non-allergic angioedema, and SCAR. Diagnosing anaphylaxis requires identifying the rapid, simultaneous involvement of multiple organ systems using a rigid 3-pathway criteria. The first criterion is met if skin or mucosal involvement is paired directly with either respiratory distress or a drop in blood pressure. The second triggers if 2 or more specific organ systems are rapidly affected following exposure to a likely allergen. The third criterion relies on a single symptom: sudden hypotension immediately after exposure to a known specific allergen. You do not need to wait for shock. Hypotension is only one possible pathway. Rash and wheezing already meets the threshold.
These rapid reactions are triggered by exposure to certain foods, like beta-lactam antibiotics, insect stings from bees and wasps, or specific vaccines. Additionally, medications like non-steroidal anti-inflammatory drugs can directly activate mast cells independent of IgE. If a patient is already experiencing an allergic reaction, taking an NSAID will accelerate mast cell degranulation and worsen the anaphylaxis. Applying these exact criteria allows clinicians to recognize the physiological cascade early and administer therapy before irreversible cardiovascular collapse occurs. Once the diagnostic threshold is crossed, the immediate next step is intramuscular epinephrine. In the setting of true anaphylaxis, there are 0 absolute contraindications to this injection. Following epinephrine, you must deploy supportive adjuncts. This includes securing the airway, providing high-flow oxygen, aggressive IV fluid volume resuscitation, albuterol for bronchospasm, and H1 and H2 histamine blockers. Intravenous epinephrine is strictly reserved for refractory cases. You only move to the IV route if the patient fails to respond to multiple intramuscular doses and adequate fluid loading. If the patient is on a beta blocker, epinephrine may fail to exert its intended vascular effects. To bypass the blocked beta receptors, you administer glucagon, which independently increases intracellular cyclic AMP to reverse the reaction. Patients who require multiple doses of epinephrine or who initially present with severe respiratory or cardiovascular compromise must be admitted to the hospital. They are at high risk for a biphasic reaction, where symptoms return after an initial resolution. Standard protocols mandate prescribing an epinephrine autoinjector and providing explicit instructions on how to use it. This protocol is entirely rigid because systemic vasodilation accelerates rapidly. The window to intervene and reverse the cascade closes in minutes. If the histamine response is localized to the dermal layers, it is evaluated as isolated urticaria. The primary clinical divider here is the 6-week threshold. This flowchart outlines the standard treatment protocols for urticaria. For acute presentations lasting less than 6 weeks, no laboratory workup is required. The initial management is strictly empirical, using a second-generation H1 antihistamine. If the acute symptoms escalate to moderate or severe, the protocol expands to include H2 blockers, and in the most severe cases, a brief course of oral steroids. This table details the presentation of chronic spontaneous urticaria, defined as symptoms persisting beyond 6 weeks without an apparent trigger. Unlike acute cases, chronic urticaria is typically driven by an underlying autoimmune process, or remains idiopathic, rather than stemming from a direct allergen exposure. Because of this autoimmune association, the chronic timeline mandates a baseline laboratory evaluation. This consists of a complete blood count, inflammatory markers like ESR or CRP, liver function tests, and a urinalysis. A routine skin biopsy is not standard. It is strictly reserved for cases where you need to clinically exclude urticarial vasculitis or mastocytosis. Returning to the treatment flowchart, if a patient with chronic urticaria shows no improvement after 2 weeks of a standard second-generation H1 blocker, we move down the algorithm. Escalation requires increasing the dosage of the current H1 blocker up to 4 times the standard amount, adding a first-generation H1 blocker at night, incorporating an H2 blocker, or introducing a leukotriene receptor antagonist. Isolated urticaria is managed strictly through symptom suppression. It is only when the condition persists beyond 6 weeks that it justifies an autoimmune investigation. When swelling involves the deeper dermal and subcutaneous tissues, the resulting angioedema must be rapidly classified.
You have to determine whether it is driven by the histamine pathway or the bradykinin pathway to prevent complete airway obstruction. Histamine-mediated angioedema is clinically identifiable by the concurrent presence of intensely itchy urticaria. Because it relies on mast cell degranulation, it readily responds to epinephrine and antihistamines. Hereditary angioedema, or HAE, operates differently. It is caused by a deficiency or dysfunction of the C1 inhibitor protein, which leads to a massive, unregulated accumulation of bradykinin. You identify HAE by the complete absence of urticaria. Laboratory testing will reveal low C4 levels, and patients frequently present with severe bowel wall edema, causing abdominal pain, alongside life-threatening laryngospasm. Because histamine is not involved, this form of angioedema is completely resistant to epinephrine and antihistamines. To halt the swelling, you must administer C1 inhibitor concentrate, a bradykinin antagonist, or ecallantide. Moving past immediate reactions, we evaluate severe cutaneous adverse reactions, specifically SJS and TEN. Unlike the immediate, IgE-driven eruption of hives, SJS and TEN are cell-mediated, type 4 hypersensitivity reactions. The presentation is delayed, typically occurring 4 to 28 days after exposure to the triggering drug. The clinical course begins with a flu-like prodrome, rapidly progressing to targetoid skin macules and extensive epidermal necrosis. A mandatory diagnostic feature is the severe involvement and sloughing of 2 or more mucous membranes. Selecting the correct intervention requires isolating the exact mechanism driving the tissue damage, whether that is histamine, a localized bradykinin surge, or cytotoxic T cells. Whenever a blood transfusion triggers an adverse immune response, the absolute first step is to immediately halt the transfusion. From there, you must separate a mild urticarial transfusion reaction from a severe anaphylactic one. An urticarial reaction is limited to isolated skin hives. The patient maintains normal hemodynamics and respiratory effort, allowing the reaction to be managed safely with standard antihistamines. An anaphylactic transfusion reaction features rapid onset shock and severe airway compromise, requiring the immediate administration of intramuscular epinephrine. The most heavily tested etiology for transfusion anaphylaxis is an underlying previously undiagnosed IgA deficiency in the recipient. These patients possess preformed anti-IgA antibodies that aggressively attack the trace amounts of IgA present in standard donor plasma. To prevent fatal reactions, all future transfusions for this patient must utilize either extensively washed red blood cells or products sourced strictly from IgA-deficient donors. Intravenous blood products deliver a massive, concentrated protein payload straight into circulation, instantly exposing these latent humoral immunodeficiencies. When administering immunizations, true anaphylaxis to a specific vaccine component acts as an absolute contraindication to any future doses of that exact formulation. We separate vaccines into killed and live attenuated groups. The primary live vaccines are the measles, mumps, and rubella vaccine, varicella, and the live intranasal influenza formulation. Regardless of a patient's allergy history, live attenuated vaccines are absolutely contraindicated in pregnant women and severely immunocompromised individuals due to the risk of uncontrolled viral replication. However, you must differentiate true allergic reactions from normal physiological responses to the vaccine itself. It is highly common for patients to develop a mild fever and a maculopapular rash 1 to 3 weeks after receiving the MMR vaccine. This is an expected, self-limiting sign of the attenuated virus replicating in the host. It is not a type 1 hypersensitivity reaction. The required management is reassurance alone. Similarly, if a patient presents with a moderate to severe acute illness, this is merely a precaution to briefly delay vaccination. It does not permanently contraindicate the vaccine. Accurately classifying a normal physiological response against true hypersensitivity is critical. It prevents the dangerous and inappropriate avoidance of life-saving medical interventions down the line.